right, so we're going to finish up our second section here in farm and then move on to the third section. Any questions from the last time? Any percolating thoughts from the weekend? You know, like, yeah, I was just thinking about farm and drugs and not while doing them, but while I was just thinking about them. Anyway, nothing? Okay. Finish up talking a little bit about what are the reasons why people might have kind of some variation in their response to drugs. And there's kind of four general mechanisms. There's probably more than this, but these are the main ones you might run into most frequently. So some of those things include things like, well, how much drug is actually getting to the receptor? So if more drug is getting to the receptor, what do you think that would do? More effect, less effect? Probably more effect, right? More drug at the receptor, more likely to have that binding occur, more likely to have some drug effect. However, if you have less drug getting to the site, guess what? Less effect would occur, right? There could be some variation in some of the endogenous ligands. So that could be something where, especially if a drug is competing with an endogenous ligand, maybe you have an antagonist that's made to block the effects of an endogenous ligand. That could alter the effects of the drug. So if I have more ligand around, that could affect how well the drug is going to work. Or conversely, if I have less ligand, that could also make the drug work better potentially. We've talked a little bit about how we can change the number and the function of receptors, how that can have a big role in drug variation or the response to drugs. And then some of the downstream components here. So we're looking at some of the secondary messenger systems, some of the things that change downstream from where the drug binds to the receptor that may affect how the actual drug's going to work. So I'll show you some examples of these as we go forward. Okay, so looking at how much drug is actually getting to the receptor, these are usually going to be pharmacokinetic changes. Remember, what is pharmacokinetics? What the body is doing to the drug, remember? So this is like the absorption, the metabolism, the distribution, the excretion, all that good stuff is going to be pharmacokinetics, right? So what the body is doing to the drug specifically. And so you can have things like upregulation of hepatic enzymes. We're going to talk about metabolism in greater detail later on in this class. However, if you have things that maybe you upregulate the number of enzymes available to break down drugs, say those increase, what do you think that would do to your drug concentrations? So if I have more enzymes available to metabolize the drug, that should make concentrations of the drug go up or down? Should go down, right? So if I have more enzymes, I'm going to have less drug available, which means less of it gets to the receptor, means less drug effect's going to happen there. A really good example of this is a drug called carbamazepine. A brand name for that drug is called Tegretol. It's used for seizure disorders originally, but we use it quite frequently for bipolar disorders, what we call a mood stabilizer. Kind of helps people from vacillating from bouts of mania to depression. And so it has what we call autoinduction of its own metabolism, which basically means the liver is going to be the primary organ that will metabolize that drug. However, after you give the drug over, say a few days or so, the liver's response to that drug is going to be to upregulate or start to increase the number of enzymes available to metabolize it. So that way, if you were to look at the concentration of the drug over time, let's say, for instance, I'm looking at just kind of the average concentration of the drug as I'm going along, you would notice that I would maybe start up here, but as those enzyme concentrations start to climb, you're going to start to notice that the average concentration is going to start to drop down, which means the drug's going to be less effective, which means what am I going to have to do to make the drug more effective? Increase the dose, absolutely. So you're going to see when you're looking at, for instance, carbamazepine, if you were to look it up in, say, a drug dosing reference like Lexicomp, that's the one I always go to most frequently, it's one I've used most often. And that actually linked up, if you look at, you guys are familiar with UpToDate? Everyone's going to become very familiar with UpToDate. It's going to be like kind of your primary source for like, if you're like, well, how do I treat this disease, or what is this disease in the first place? UpToDate's usually the place you go to. It's available through the Nova library, but that is actually linked up. They're owned by the same company, but the drug references within UpToDate will link back to a program called Lexicomp, and I can show you some tutorials on that later on if you'd like. Now I get you a little bit more comfortable with that. However, if you look at the dosing regimen for carbamazepine, you'll notice that you start at maybe, say 100 milligrams a day, right? So you're taking that one time a day. And then, for instance, after week 1, you're going to bump that up to 150 milligrams a day. And then after week 2, as those enzymes continue to upregulate, then maybe 200 milligrams a day. The point of doing that is at a point, the liver is not going to continue to upregulate kind of ad infinitum. There's going to be a balancing out point. There's going to be an equilibrium that's established to where you're going to be able to get a good steady state sort of drug level. We'll talk about steady state means later, but you get a good drug level based on the dose you're receiving because the liver's not going to stop that autoinduction essentially, right? That's one way to do it. Other factors can play a role here as well, though. You can have things like age can play a role. We'll see what the extremes of age, what effects that has on the pharmacokinetics. Yes, sir.
So if you're at the highest level of enzyme production in your liver,
Mhm.
would that cause damage if you're constantly at that level?
Some drugs are going to be inherently hepatotoxic, right? Some drugs are just going to have an ability to damage the liver. Some drugs are not ever. It's kind of a wide range of scales there. It just depends on the situation. In some cases you're going to find a lot of these drugs that are heavily metabolized in the liver, they tend to be a little bit more hepatotoxic, and we can monitor for those sort of things. Some people may also be more likely to develop toxicity than others. So just because I give a high dose of drug to one person, their liver may develop injury. And how would you detect that injury? How could you tell?
Liver function test?
Yeah, usually liver function tests are the big thing you're going to measure. So AST, ALT are big things you're going to measure. I'll tell you another thing, and you guys learned about this in Clin Lab, I believe. Remember the clotting cascade? Remember where some of those clotting factors are made? In the liver, right? So if your liver function is diminishing, what do you think your ability to produce those clotting factors is going to be? It's going to go down as well. So actually, one of the big things we measure, or especially kind of more extensive damage done to the liver, especially with drugs, we measure PT-INR. You guys familiar with PT-INR? Right, so again, we measure that, and that can actually tell us how well the liver is functioning. Because if it's not producing clotting factors, your PT-INR is going to go up because you're more likely to bleed, and that's a pretty bad sign that your liver's not doing too well. So as a tangent there. But yeah, so again, these drugs have a possibility, but they don't always do that. So anyway, some other things like different disease states, genetic differences, all of this can affect how well the enzymes are going to be metabolizing that drug, more or less so, and that can affect how much the drug actually gets to the receptor. Okay, you can even have change of some of the active transport. So remember we talked about active transport requires ATP, can move things across biologic membranes. We have things like multi-drug resistance transporters, right? So these are proteins that are meant to basically they will efflux drugs out of a cell in order to prevent it from having its effects, essentially, right? So you see these frequently with things like, bacteria. They can produce multi-drug resistant transporters to try to keep antibiotics out of the cell, because again, it's poison to them, essentially. And all of that can play a role. So again, if those are upregulated and I'm forcing more drug out, then the concentrations go down, essentially, right? Other things we'll find is that you can actually have tumor cells that will develop resistance to this, right? Because again, if I'm constantly, killing these cells off with chemotherapy, they're going to want to develop resistance. We know cancer cells, are they kind of slowly replicating, quickly replicating? Very quickly, right? So they can introduce a lot of new mutations that can produce this resistance here. So you may find that some drugs are really effective for a good long period of time, and then all of a sudden they will start to generate that resistance, and then the drug's effect will go down, right? Just based on these mutations that occur there. So these are just some examples. Again, I'm not going to ask you specifically about carbamazepine on the test. However, I may say, hey, with carbamazepine, you notice these enzymes upregulating. What is that an example of? And you can say, well, this is an example of altering that drug concentration at the receptor, right? So again, know the concepts. Okay, so sometimes you can have variations in the endogenous ligand. So a good example of this is a drug called propranolol. Anyone ever heard of propranolol? It's what we call a beta blocker. It's used for all kinds of different things. Sometimes we'll use it for hypertension. Sometimes we'll use it for arrhythmias. Some people may have even used it if you have like a public speaking fear, or if you have like a performance anxiety. Some people will take this to help calm the nerves down a little bit, because it blocks the effects of things like epinephrine and norepinephrine. We know that those two are really big components of what type of nervous system? The sympathetic nervous system, right? So if I get really nervous when I come up here and talk in front of you guys, I'm activating that sympathetic nervous system, and so it's going to cause me to be kind of tremulous, and my heart rate's going to go up, and blood pressure is going to go up, and breathing faster. We don't want that to happen, so I can use a drug like propranolol to block the effects of things like epinephrine and norepinephrine, right? So what can happen is if I end up increasing the levels of catecholamines, so I'm trying to reestablish homeostasis, my body could try to increase levels of epinephrine, and that can actually block the effects of the drug, basically because they're competing for the same receptor site. If there's enough epinephrine, they'll knock that propranolol off, and then the epinephrine can then have its effects again, right? So all that may be related to the dose of the drug that I'm administering. Maybe I need to give a bigger dose, but again, it all goes back to how much of that endogenous ligand I have available to interact with that receptor, right? So. In some cases, you may find, for instance, like if I was taking propranolol for stage fright, if I'm in a state where I'm not actually going to increase that fight or flight response. So for instance, maybe the first time I ever taught here, I was a little nervous. That sympathetic nervous system's upregulated, and I take the propranolol, that would work very well. However, if I come in here, I've been doing this for teaching this class, this is my 5th year. How nervous do you think I am teaching you guys now? Not very, right? Maybe the first day a little bit, but at this point, we're old friends now. I can come in here. Upregulation of my sympathetic nervous system is not really happening so much. So at that point, I can take beta blocker like that, but it's not really going to do a whole lot, because there's not a whole lot of catecholamine for it to really to affect it, essentially, right? So again, there's cases where it can kind of go either direction. Yes, sir. Klonopin works through a different mechanism. You could still use that for anxiety, but unfortunately, Klonopin, that's actually working to more kind of slow down the CNS a little bit. So it's we call it benzodiazepine, or if you ever heard of a benzo, it's like a Xanax. That can also be used for anxiety, but the unfortunate drawback of a drug like that is it kind of can increase, make you sleepy essentially, right? So again, if I need to perform, if I need to be up here and speaking and remembering all these facts and things to reiterate to you guys, that may actually inhibit that because my brain's kind of working a little bit slower than it would otherwise, right? It's kind of like taking a shot of alcohol before you get up to give a performance or something. Not that I recommend you do that. I highly recommend against that. It's probably not going to go well for you, but that would work via a different mechanism to achieve basically the same ends, right? Okay, so you can change the number of receptors. Again, this can either increase or decrease. We've talked about upregulation and downregulation of these receptors before. This can sometimes be caused by hormones, right? So thyroid hormone, if that is up, if I have increased levels of T4 and T3, remember which one's more active? Remember, T3 is a more active form. That can actually increase the number of beta receptors that are available on the heart. So if I increase the number of beta 1 receptors there in the heart, that means that they're more likely to interact with things like epinephrine. And so that can lead to things like hyperthyroidism. You see thyrotoxicosis. Remember how that manifests? What does it do to heart rate when you have too much thyroid hormone? Usually increases it, right? And some of it is related to the heart being more sensitive because there's more receptors to interact with the sympathetic nervous system, right? So that's one thing. You can also have what we mentioned, tachyphylaxis before. Remember what that was? Or that's a case where it doesn't matter how much you increase the dose, you're not getting any additional effect out of that drug. And then tolerance was different than that. How was tolerance? Or what it was tolerance? That's where you could increase the level of the drug to get more effect out of it, right? So again, with some drugs, you'll get tolerance to, where if I continually increase the dose of the drug, I continue to retain the effect. With tachyphylaxis, remember that nitroglycerin example, I have to do 12 hours on, 12 hours off, because otherwise it doesn't matter how much nitro I give, it doesn't cause any more effect, right? It's not going to affect my chest pain, essentially. So again, all that can be related back to the number of receptors that are available. If you're downregulating or upregulating them, that can cause pretty drastic effects on how well the drug's going to work for the patient, right? There's a case where we can have desensitization, where maybe if you're continually providing an agonist to the receptors, or potentially an antagonist in some cases, you may find that the receptor itself becomes more or less sensitive to the effects of that ligand, right? And because a lot of times this is kind of a defense mechanism for the cell, right? Because again, if I have too much excitation, potentially, that can cause cellular damage, can cause apoptosis to trigger. We don't want to do that. So typically you can find either the cell receptors can downregulate in number, or they can become more, they can be less sensitive essentially. So that way the drug is coming along and may not get the same kind of 100% effect you would expect, maybe downgraded to like maybe 75%. And that again is trying to maintain homeostasis and protect the cell essentially. And then when you see this, we mentioned tachyphylaxis. So again, desensitization can happen. This is one mechanism for that, where again I can give as much drug as I want. I'm never going to see any additional effect through that tachyphylaxis. Usually, do you think the receptors ever resensitize or get more sensitive again? How could I cause that to happen? Take the drug away, right? So sometimes we'll have what we call like a drug holiday, where basically you'll take a person off of a medication for a period of time to allow their body kind of to reset itself a little bit, kind of get used to not having the drug around, and then you can reintroduce it. And typically those receptors will resensitize, and you're going to find the drugs tend to work just like they did before, basically when the person had started the drug the first time. Yes, ma'am.
Does that sometimes happen where you reintroduce the drug and then they become sensitized even faster?
It's a good question. I'm not sure of any clinically relevant examples where that occurs. I'm sure you may find in some cases, because I mean, for instance, like if you look at something like Parkinson's, right? Parkinson's, you're going to learn probably in your neuro block of CMAS or in pathophys. That's basically a destruction of the dopamine neurons, right? And so I can give drugs that will help to replicate that, but you're going to find they become less and less effective over time. That's one of those things where even if I take the person off the drug for a period of time, they're still having destruction of those dopaminergic neurons. So when I reintroduce that, you may find that you don't really still get that same benefit out of that, right? Because there's less neurons to really become more sensitive to it, essentially. So that may be one example. I'm trying to think of anything else clinically relevant where that would have happened, but nothing is truly coming to mind. So it just depends. Some receptors sensitize more slowly than others. It just depends on how long the person's off the drug as well, right? So good question. Yes, sir.
Desensitization cause tolerance?
That can be one mechanism for having some tolerance, right? So depending on how much desensitization comes on, it may develop into tachyphylaxis, or it may just be tolerance in those cases, right? Because really tachyphylaxis is just a more kind of extreme form of tolerance, to where increasing the dose doesn't have any real effect, versus tolerance I can overcome that by increasing the dose. Yeah. All right. So just an example looking at desensitization. Laser pointer. So again, looking at drug effect over time. So again, by giving repeated administrations, you're going to notice that peak effect, that Emax essentially, is going to be diminished over time. However, if I give the body a break, then I can go ahead and when I re-administer the drug, you should see pretty close to peak effect, just like you did before. So this would be an example like nitroglycerin, where I can go ahead and as I continuously administer that drug, it becomes less effective. I give the body a 12-hour break or so, come back, give more nitroglycerin, and then I'll have peak effect again. Okay, so one example of that. Sometimes we'll have what we call a refractory phase, or kind of an unresponsive phase, and that's where, again, during that recovery period where the drug's not working all that well, that's what we call kind of refractory, where the patient is not responding as we would wish, right? Okay, so looking at some of the rebound phenomena, so this is kind of an interesting thing where drug withdrawal, taking someone off of a drug abruptly, can actually cause some rebound effects that can be lead to some pretty significant side effects, or some pretty significant adverse effects here. So for instance, we're looking at beta blockers again, so we're looking at propranolol. Normally a medication which is going to block beta-1 receptors in the heart and actually slow down heart rate, and usually will lower blood pressure as well, right? So in response to that, by blocking up all of those beta receptors, what do you think the body wants to do? Upregulate or downregulate? It wants to upregulate, right? Because I'm blocking all those receptors. So it says, hey, I need more epinephrine effect around here. My heart rate's too low. My blood pressure is too low. Tries to increase the number of receptors available. So you have upregulation there. I'll show you a picture in a second. However, when I withdraw that beta blocker immediately, do the receptors just go back to the normal number immediately? No, it takes time. So now I have all these extra receptors. They're not being blocked anymore. And now I have that epinephrine coming along. And what do you think is going to happen to the effect of that epinephrine? Is it more effective or less effective? Much more effective than it would be otherwise, because there's more receptors for it to bind to, right? More receptors means more cell signaling occurring there. There's more of that cyclic AMP that's being formed, more of that protein kinase being activated. Remember the secondary messengers? All that's still happening, and then you're getting the kind of the increased dramatic effect. So, an example of this, imagine we have normal ligand, these triangles are epinephrine, we have the receptors here. Oh, yes, ma'am.
Sorry, is that like similar to like Xanax, when people come off Xanax, they become like more anxious, or is that just like?
Yeah, I'll talk about that in a second. That's the same exact mechanism here, essentially. So I'll talk about that in a minute. Right. So imagine these are epinephrine molecules, these triangles here. Imagine these rectangles are going to be the receptors, and this is your biologic memory. This is your phospholipid bilayer here on the cell. Imagine this is a myocyte we're looking at, right? These are beta-1 receptors on the heart. We'll cover that more in physio later on, but just know beta-1 receptors are the big movers and shakers on the heart. So imagine, we go ahead and we have our drug binding here, and we have, let's say heart rate 75, blood pressure 145/90. Okay, that's fine. That's it's a little high blood pressure, right? Normally, like what to be our normal blood pressure? 120/80. So let's say we go ahead and give something like an antagonist. Let's say we're going to give some beta blockers here. And so now our heart rate goes down to 60, because now epinephrine cannot bind to those receptors, and the blood pressure comes down to where we want it to be. Great, right? So the body's responding by increasing the number of those receptors, which normally there'd be enough beta blocker around to overcome that and be able to bind to those extra receptors. That'd be fine. However, if I withdraw the drug immediately, all of a sudden all these receptors can now be bound up by epinephrine, and now what do you notice about the heart rate and blood pressure? Goes up higher than what it was before you even started the drug in the first place, right? That's what we call a rebound phenomenon that can be very drastic in some cases. And imagine if you have someone who has myocardial ischemia, maybe someone who has a history of MI maybe, and they already have a problem where they can't deliver enough oxygen to the heart under stress. This is a big stressor right here, and so this has actually induced heart attack in some people and killed them, right? So in some drugs, you want to taper off slowly to allow for those receptors, or whatever mechanism is going on, to try to kind of recalibrate themselves over a long period of time in order to prevent these withdrawal phenomenons. Same thing happens with, so you mentioned Xanax. That's a benzodiazepine. We'll use it for seizures in some cases because it helps to slow down the CNS. We'll use it for anxiety, for all kinds of different things. And so what happens there is that by administering Xanax for a long period of time, those are actually affecting GABA. Remember we talked about GABA? Remember what that does for us? It's the brakes on the system, right? It's the brakes on our CNS. Basically, it tries to hyperpolarize those cells by allowing chloride to flow in, and we'll try to prevent action potentials from occurring. That's how we stop seizures. That's how we can help to slow down or help the patient's anxiety, is by trying to increase that GABA effect. So what happens there is I'm giving those benzodiazepines. I'm chronically having kind of increased effect from GABA. There, you're going to be having more of kind of a downregulation that occurs there, right? So I'm going to have less GABA receptors that are available to kind of interact with the benzodiazepines. Now, all of a sudden, when I take that away, the body's used to having all that effect around, right? So when I take that away immediately, now I go from a case where I'm being more inhibitory, I move over, and now glutamate's starting to take over and very excitatory. So people, when they withdraw from a benzodiazepine, they get rebound anxiety typically, or some people may actually have seizures from this. Same thing happens with chronic alcoholics. If they drink all the time and all of a sudden they run out, they can have these withdrawal seizures that occur that can be potentially deadly. You in the back had the question first.
Is this the same effect with prednisone?
Yeah, so with prednisone, that would be basically working as a glucocorticoid. We talked about those in physio, right? Those are being released by the adrenal glands. In that case, you would actually see by giving exogenous corticosteroids like prednisone, or if you like taking like a sodium medrol dose pack, so methylprednisolone, dexamethasone, lots of different ones. But if you give it for a long period of time, by giving exogenous steroids, your adrenal glands, they say, well, we got enough steroids around here. Let's go ahead and downregulate our production of our endogenous cortisol, right? So you start to have cortisol being released in lower amounts. And all of a sudden, if I take that away, that extra prednisone, guess what happens? The adrenal glands take time to ramp back up. And so now you don't have enough cortisol around. You lost the extra steroids you're giving exogenously. And all of a sudden, they're in basically in adrenal crisis. They're in this adrenal insufficiency. So again, these are different mechanisms for basically the same thing that's happening here. These withdrawal phenomenons, basically they're the opposite of whatever the drug was doing in the first place. So if I was giving a drug to lower blood pressure, and I take that away immediately, I'm going to see an increase in blood pressure. If I'm giving something to help increase the amount of steroids in the body, and I take that away, I'm going to have lower steroids circulating in the body, essentially, right? This doesn't happen with every single drug, but there's notable examples, and these are the ones you want to be careful of when you're withdrawing someone, or when you need to withdraw them from the drug slowly, essentially. All right, who else had a question?
So this drug is as needed, right?
It depends on the indication, right? So if I'm taking for blood pressure, I might take it every single day, right? Because again, I want my blood pressure to be lower all the time, not just during certain periods of the day. However, I'm taking for stage fright, I only want to take it before that presentation or performance or whatever it's going to happen to be, right? So again, it just depends on the indication.
So if they do it for stage fright, do they feel this effect like every time they take it?
Not typically, right? Because again, if I don't have the drug around there all the time, you don't see this kind of compensatory mechanism take place, right? So again, so this is more of a problem patients who are taking it for blood pressure control or for arrhythmia control, things like that. If they only take it every once in a while, typically you don't see that. So again, if I take like a Xanax, right, which is meant to help with anxiety, if I take that every once in a while, you don't see that same effects there as well. It's only if you're taking it every single day. Make sense? And again, going back to your steroid example, that's one of those things where we only have to do that withdrawal from the steroids if you're on it for a long enough period of time to actually shut down the adrenal glands. So for instance, if I come in and have an asthma exacerbation, I'm coming in, I'm wheezing, and you give me steroids to help treat that inflammation, if I'm on it for 5 days, I don't have to withdraw from that slowly. I can just go ahead and after 5 days stop, and then I'm good to go. If it's longer than that, say for instance I have a chronic inflammatory disease like rheumatoid arthritis, and I'm on that every single day, that's where you have to be careful and withdraw from it slowly. So about a week is usually where that's going to come up. We'll talk about that later, so it's not something you need to remember now. Did that answer your question?
I'll ask.
You have follow-up questions. Perfect. Well, you can ask that later. That'll work. I like you guys have so many questions. This is great. I like having a dialogue much better than me just yapping at you guys for 2 hours straight. So it's perfect. Oops, sorry. So anyway, there's genetic factors as well that can play a role in receptor function. So for instance, if you have a certain deletion in this alpha-2C receptor, this can affect G proteins as well. You may have increased cardiovascular response to stressors. So maybe you're more likely to respond to things like epinephrine. You're more likely to have hypertension and increased heart rate, things like that. And depending on the patient population, you may find that African Americans may be more likely to express it than certain other patient groups. Sometimes you may find these may not prove to be always clinically important. So you may not always be screening for these sort of things. Sometimes you may find it becomes very, very important. You have to make sure that, and this may actually decide like, okay, well, in this type of patient with this, maybe they have a Middle Eastern background, we use this particular drug versus they're Caucasian, they'll use this type of drug. And so that can sometimes be clinically relevant, but genetics do play a factor here. Okay. Sometimes you'll see kind of downstream effects that can occur secondary to the effects of the actual drugs themselves. So even though it binds to one receptor, you may find that the body has other means of trying to compensate for the effects of that drug. So for example, let's go back to our beta blocker. Say we're giving a beta blocker to block up our beta receptors. We're going to be helping to lower blood pressure. And again, typically working the heart to actually lower blood pressure. We'll talk about how that works in cardio later on in Pharm 1. But just know by working on the heart, it's helping to lower blood pressure. Okay, so you're going to find that, you may find really good effects on lowering the blood pressure over time, but what you find is that after a while, the blood pressure starts to creep back up because, again, the body usually when in a chronically hypertensive patient, their body is now used to that new blood pressure. That's their new normal, essentially. Maybe 150 over 90 is like that. That's just their blood pressure now. So when I try to lower that, what does the body want to do? Let's go back up to that new normal, even though that's the wrong normal. That's the body what it thinks is normal. So we'll find that the kidneys are another huge organ that is not the kidneys should be huge, but they play a large role in trying to regulate blood pressure, mainly by working through the renin-aldosterone angiotensin system. You don't have to remember that now. Just know that it's going to be a big player. We're talking about blood pressure later on. But by trying to hold on to more water, that's also going to help to, and salt as well, is going to help to increase blood pressure as a compensatory response. So you may find that the beta blocker works for a while, becomes less effective, and that's mainly due to downstream effects with the kidneys. And so I can give potentially another drug to counteract that, and all of a sudden blood pressure goes back down to where I want it to be. So again, sometimes downstream effects can make your drugs less effective over time, because the body is always trying to maintain homeostasis. This is always the body's number one rule of law. Okay, any questions on that so far? All right, moving on to talk about clinical selectivity. So kind of looking at beneficial versus. So when we say selectivity, we're going to find that you have some drugs that are very selective for only one type of receptor. Some of them tend to be less selective and can interact with all kinds of different receptors there. And so, again, a lot of that's based on affinity. Some of it is based on dose. You tend to find that, and say for instance, I have a drug that only blocks beta-1 receptors. If I increase that dose, you can always find there's a bleed-over effect that occurs at high doses, where maybe it'll affect other beta receptors, right? So maybe beta-2, maybe beta-3. So again, a lot of this is dose dependent, and usually we're going to find that the more selective a drug is going to be, the more useful it's going to be for our clinical medicine, right? May be more expensive, may not always be super practical. However, we like selectivity when possible, right? So a good example of this is the insecticides you may actually use in your home, right? So again, this is not a drug used on people, hopefully, but for killing bugs, we like things that are very specific. So for instance, if you use like kind of old school sort of pesticides, you have things called organophosphates. These are not very selective for killing the bugs. They actually have a very good ability to interact with people too. So if kids were to get into this, they become very, very sick. I'm not going to go into the mechanism there, but just know that it's very, very dangerous if you were to get into an organophosphate. You don't see it very frequently because, because we have a kind of more developed country here, you're going to see that we've moved over to using things like pyrethrins, which tend to be much more selective for affecting the insects. And because of that, even if a person accidentally ingested some, you really don't find any bleed over effect because the drug is so specific for the insects, it doesn't affect us as much. Okay. However, you can certainly still find organophosphates, especially in more developing countries. You go over there, they find organophosphates all the time. They're very effective at killing the insects. However, very also effective at killing people as well. So again, selectivity is always a good thing. All right. You can determine selectivity usually by comparing ED50s between different drugs. Remember we talked about ED50s and those curves. That allows us to determine kind of the potency and how it's going to be interacting with the receptors there. And then what you're normally going to find here is that when we're kind of developing drugs, in the first place, we're kind of put their effects into two different categories here, either the therapeutic effects or the toxic/side effects, right? So again, ideally, we'd like a drug with only therapeutic effects and no side effects. However, is that ever possible? No, again, every drug is going to have a side effect. Anyone familiar with the Roseanne debacle that happened recently? She complained about like her Ambien tweeting causing her to be like super racist, and then the manufacturer of Ambien came back and they said, well, all drugs have side effects. However, racism is not one of the known ones for Ambien. I was like, man, that's pretty bad when the pharma companies are kind of the good guys on that one. So not a common occurrence there. But anyway, so again, every drug is going to have some degree of side effects. It's just a matter of like what's going to be tolerable, what's going to be, some patients are going to be more prone to some than others. And we're going to look at that as we get into individual drug examples. So again, looking at the beneficial and toxic effects being mediated by the same receptor. So again, this is one of those ones where you really can't differentiate the beneficial from the toxic effects. So they happen through the same mechanism, right? So a good example of this would be something like warfarin or Coumadin. We mentioned this is a rat poison. Still sometimes used as a rat poison. However, it's very good for thinning out the blood because it actually works in the liver to prevent production of some clotting factors, right? So this is another one that affects your PTR pretty significantly. So again, if I have a patient who has maybe a risk for thromboembolism, say for instance they have AFib and they're more likely to have a stroke because of that, then perhaps I want the warfarin around to thin the blood to make it less likely to clot up. And that's a good thing. However, if I increase the dose and I go too far, then what am I at risk for? Bleeding at that point, right? So again, that's an extension of its mechanism of action, that if I have enough around, then it causes good therapeutic effects. My blood is thinned. If I have too much around, that's where it's going to be a problem. I'm going to have bleeding being my main problem there. So again, that's through the same exact mechanism. Imagine insulin. We give insulin to a diabetic patient. Their blood sugar is too high. I give them insulin. It should bring it down to a normal range. If I give too much insulin, guess what happens? get hypoglycemic, right? So again, that's a huge risk factor. You'll find that insulin is what we call a narrow therapeutic index drug. Remember what that means? It's very easy to go from a therapeutic dose to a toxic dose. You have to be very careful with insulin in the hospital setting, especially because we're producing all these different doses for patients. And if you give the wrong one to the wrong patient, or you give too much or too little, bad effects can occur here. But it's all through the same mechanisms as the actual drug itself, right? So again, in these cases, you have to weigh the benefit versus the risk. So a good example of this, something like warfarin, where if I have an elderly patient who develops AFib, I'm worried about them having a stroke and due to a clot formed in the atria. So I give them warfarin to try to prevent that clot from forming in the first place. However, if I have an older patient, maybe their gait is kind of taking a hit, maybe they're not able to get around as well. Old people tend to be more likely to have what as well? Fractures. Falls and then fractures, right? So that's a big thing. So again, someone has a fall and hits their head, what are they likely to do? Bruising, bleeding. If they're on warfarin, guess what? They're even more likely to have a head bleed and they can die from that. So it's always a risk versus benefit sort of thing of like, okay, well, is this the right drug for this patient? What are their risk factors? How do I decide who the best patient is going to be for this drug? That's a big component of Pharm 1 and Pharm 2 is determining, okay, well, I have all these drugs here. I have this giant, pharmacopoeia of different medications. How do I decide which one's best for my patient for this particular disease state? And that's a big thing we're going to look at is weighing the benefits versus the risks that they can have due to the toxic effects. Okay, so in some cases you may find that we're having the beneficial and toxic effects happening through identical receptors, but they're actually in different tissues, or they may be through different mechanisms. So for instance, if I have someone who's having, say for instance, like I say, an asthma exacerbation, or if they're having a COPD exacerbation, the main problem is in what organ with asthma? The lungs, right? So the lungs are the main problem, right? I'm having too much inflammation in the lungs. I can't breathe very well, right? So I can give them something like prednisone, give them a steroid to try to help block that inflammation, right? And again, these specific mechanisms are examples. You don't have to memorize this for the test, but again, these are illustrating the concepts here. So prednisone, I can give it orally, and it's very good for helping the lungs, but does it just work in the lungs? Can I just tell the prednisone, hey buddy, go hit the lungs, don't attack anywhere else? Does that work? Unfortunately, no, right? It'd be very nice if we had very well-directed drugs, but we don't. And so it goes and affects the entire body, essentially, right? So this means I can see increased glucose, right? Just because it's a glucocorticoid. Remember that cortisol and drugs that work like cortisol are increased blood glucose. So you can see things like increased glucose, so diabetes gets worse. You can see fluid retention as well happen. So again, these toxic effects are due to its actions in different tissues than the one I was really concerned about in the first place. Now, sometimes you can get away with it, or you can get around this by using specific dosage forms. So for instance, I don't know if any of you have asthma or any family members have asthma, but there's actually inhaled steroids you can use. And that's very good because it gets the steroid right to the lungs, and you don't see a lot of absorption into the system outside of that. So I get localized effect in the lungs where the inflammation is, and then it doesn't go anywhere else. So very limited side effects in those cases, which is a nice thing you can do. You can always try to use the lowest effective dose possible. Right, that's always going to be a good thing to try to do. Or you can try to use drugs with a different mechanism of action. So for instance, instead of using something like an insulin causing hypoglycemia, maybe I can try using a different drug works through a different mechanism to help regulate the blood glucose, right? So again, these are different goals we can try, and we'll talk about these different instances and how we can get around some side effects later on in Pharm 1 and Pharm 2. Okay, sometimes you're going to find toxic effects are mediated through different receptor types. So for instance, we can find that certain drugs are going to be less selective and they bind to lots of different receptors. For instance, epinephrine binds to alpha, beta, and to other various receptors throughout the body. And so this can lead to different side effects that you may not be looking for. So for instance, you may have low heart rate, and I give epinephrine to try to increase the heart rate, but it may also increase the blood pressure, which may be high already, right? So again, those are different receptors that's going to be working through. And so by making drugs more selective, you tend to decrease some of the side effects that are available there. So a good example of this are going to be our NSAIDs. Remember we talked about NSAIDs. What's an example of an NSAID? Ibuprofen, naproxen, aspirin falls in this category. Well, these are non-steroidal, so non-steroid anti-inflammatory drugs, right? So they're decreasing inflammation, but they're not steroids. They work through an enzyme called cyclooxygenase, abbreviated to COX. And so there's COX-1 and COX-2, and normally things like ibuprofen, they'll affect either one equally, right? They're non-selective. And one of the big side effects you're going to learn with chronic use of NSAIDs for pain is going to be you can have things like peptic ulcers develop because it actually degrades the lining of the stomach or the protective barrier there and allows for the stomach acids to start chewing through the tissue. So what I can do is by giving a COX-2 inhibitor specifically, I can spare the GI tract, I can keep that intact, but still deal with the inflammation. So one way I can get around that by being more selective and only picking one enzyme I want to affect. Another good one, it would be something like our histamine blockers. So for instance, if I have an allergy, I might take a drug like Benadryl, right? So I'm having seasonal allergies, take Benadryl. That's an H1 blocker versus something like if I'm having GERD symptoms, if I'm having acid reflux, I can take an H2 blocker that just affects the GI tract. So again, selectivity can be a way of getting around some of the side effects. Okay. And you may find that actually side effects lead to drugs being used in a new manner. So everyone familiar with the drug Rogaine? What do we use Rogaine for? For hair growth, right? So this is a drug called minoxidil, it's a generic name, and originally it was used a long time ago to try to lower blood pressure. It was okay at lowering blood pressure, but what they noticed is all these patients started to develop all this kind of abnormal hair growth, right? What do you call that? Remember the name? Yeah, hirsutism is what we call it, and have abnormal hair growth, especially due to medication here. And so they found this increased hair growth, and they're like, well, that's kind of weird. Let's try using this topically. Let's just applying it to the head. And all of a sudden they realize, hey, this actually works very similarly. And so now we have Rogaine, right? So again, sometimes you'll find the drugs started life as one type of drug and then developed into something different, right? And so really when we're trying to select a particular agent for a patient, it's important to consider all aspects of the drug. So side effects, potential toxicity, and also the duration of the effect, how long the drug will actually be working for. Remember, potency is not always king, right? So again, I can get around potency by changing my dose. Efficacy tends to be more clinically relevant. However, you don't always have to use the absolute most effective drug for your patient. Sometimes you can get away with using a cheaper alternative that may be a little less effective, but still gets the job done essentially, right? So again, all these things are going to be taken into account when picking a drug for your patient. Okay, so any questions on that? All right, let's take an early 10-minute break. We'll come back and then start section 3.